can direct it to the right people, and by then we should have spent 1.5 hours, and then we call it a day. Okay. Hi, Matthew.
Hi, sir. Good evening, sir.
Very good evening. How are you? All well?
Yeah, sir, in Kerala, Cochin.
Hi.
Sir, how much time we have for the talk? They have given a case and they have given 16 slides are there. 16 slides are there.
I would, I'll tell you, both of you, Arundhati and you.
Yeah.
You see, if we start that conventional talk, which we give for 20-30 minutes, then the whole program will get messed up.
Yeah.
So, because we have 1.5 hours, we should finish by 9 o'clock. So 1.5 hours, maybe a couple of minutes up and down for that vote of thanks and all. So I would say each one of you take around 6-7 minutes.
Okay.
And then we take a couple of minutes, couple of questions, and then whatever is to be compensated, if time remains, then we can compensate that and the fag end of the whole program. But if there are any time constraints, then we'll sort of truncate it.
Okay, so we'll keep us 7 minutes.
7 minutes.
I just have 3 slides, and these are just 3 cases where we can.
It is basically a case presentation is raising a point, sort of relevance of this therapeutic modality in a given patient population and why we are deciding that. Sort of is more of a raising an awareness rather than imposing an opinion.
True. I'm just presenting 3 case scenarios where we could possibly put in an SGLT2 inhibitor, just that. And
Perfect.
Darga, sir?
Yes, sir.
Yeah. Sir, I'll be, the question portal I'll be handling. So I'll just put any question is there. I'll just put the questions in the chat box. And from that, you can begin the question.
No issue, sir. All the question is there, and we'll pick up the ones we can answer.
Yes, sure.
Professor Fisher.
We'll answer them all. We'll answer them all.
Comfortable ones we'll keep in abeyance.
Yes.
If we don't know, I'll say we don't know. It's okay. I'm quite happy to say when I know something and say when I don't.
As in a lighter way. Weather in Glasgow, Professor Fisher?
It's actually nice today, but we've had the wettest May for some 30 years. It's been very wet.
We'll be live in next 4 minutes.
You can't believe it. Most of the India is boiling at 45, and I have a heater in my room in Srinagar.
All right. Okay. No, the weather's changing here, there's no doubt. So May's normally quite warm and dry, and it's been cold and very wet, as I say. But today's nice. Today is one, and then next few days. But we're then supposed to have a heat wave in June, and normally we don't get much warmer. It's never obviously 45 until July. So climate change is real for us. It just means more rain.
Quite a few years back, I went to Edinburgh and spent a day in Glasgow.
All right, yeah.
But it was a quite wet day.
Yeah.
And most of the day then I spent in an Indian restaurant.
Yeah. No, we have lots of nice Indian restaurants, yeah. But we're going to one tonight. Yeah, we have lovely ones. Not as good as in India, but some nice ones, yeah.
So we'll be live in next 2 minutes. I hope you can hear me.
Just give me countdown, okay,
Yeah,
so that
sir,
I can start. Yes.
Yes, yes.
Dr. Mahesh has joined. Mahesh Fulwani. I don't see
Yes,
him.
sir. Yes, I just had a word with him. He's in just angioplasty. He'll be joining in 5 minutes. He just asked to proceed. He'll be joining in 5 minutes.
We'll be live in next 5 seconds. 5, 4, 3, 2, 1. We are live.
Hi, good evening, everyone. I'm Dr. Abhijit Trailokya, heading the medical department of Alchem Laboratories. I welcome you for the session on SGLT2 inhibitor, cardiorenal benefits and beyond, and we will focus on dapagliflozin. This is the international speaker program, what we are doing under the banner of Dapanam Conclave. This Dapanam Conclave is brought to you by Metabolic Division of Alchem Laboratories. For today's program, we have international faculty with us, Professor Miles Fisher. To moderate today's program, we have the moderator from India, Professor Abdul Hamid Zargar. And then we have a national faculty, Dr. Bobby Matthew, Dr. Mahesh Fulwani, and Dr. Arundhati Dasgupta. So with this, now I will take you through today's agenda. So we'll start with opening and introduction. Then Professor Miles Fisher will talk about SGLT2 cardiorenal benefits and beyond, followed by Professor Abdul Zargar. He will give perspective about usage of SGLT2 inhibitor, dapagliflozin in Indian perspective. Then we will do a few case study discussion. The first case will be presented by Dr. Bobby Matthew, followed by Dr. Mahesh Fulwani, and then Dr. Arundhati Dasgupta. After that, we will do a question answers discussion along with the panelists, and followed by closing remark and vote of thanks from Ms. Yogesh Kaushal. He is a president, chronic cluster of Alchem Laboratories, Mumbai. So with this, let me take an opportunity to introduce Professor Miles Fisher. He's an honorary professor, University of Glasgow, Scotland. Consultant physician at Glasgow Royal Infirmary from 2001 to 2020, vice president medical of Royal College of Physician and Surgeon, Glasgow from 2011 to 14, was president of Scottish Society of Physicians from 2015 to 16, and co-chair of Scottish Heart and Arterial Disease Risk Prevention in 2017. He was on steering committee of Gigami 2 study, was also involved in Hope 2 and CV outcome trials, and for the albiglutide harmony phase 3 development program. He has been involved in guideline development for Scottish Intercollegiate Guideline Network and ESC, and in guideline reviewing of ESC and EASD and NICE. He is the editor and co-editor of 4 books on heart disease and diabetes, 3 books on hypoglycemia, and books on SGLT2 inhibitor. He is the author and co-author of 49 books chapter, 82 original papers, 72 review articles, 36 leaders and editorials, and 54 drug notes for practical diabetes, and 15 drug notes for British Journal of Cardiology. So with this, I would like to welcome Professor Miles Fisher for this live webinar. So along with sir, we have Professor Abdul Hamid Zargar. He's a consultant endocrinologist from Srinagar, former member of MCI, past president, Endocrine Society of India, member Institute of Body of AIMS, New Delhi, chairman, Department of Endocrinology, director, ex officio secretary to government, Shere Kashmir Institute of Medical Sciences and Srinagar. Welcome you, sir, for this webinar. Along with sir, we have 3 panelists with us, Dr. Bobby Matthew, consultant endocrinologist, Kochi, specialized in andrology, diabetes mellitus, thyroid disorder, obesity, growth hormone deficiency, and PCOS and other hormone-related disorder. Welcome you, sir, for this program. We have Dr. Mahesh Fulwani with us. He's an interventional cardiologist from Nagpur, work as a senior resident at KEM Hospital, Mumbai, as a registrar at GMC Nagpur. Extensive experience in interventional cardiology, angioplasty, and balloon valvotomy. Welcome you, sir, for this program. And we have Dr. Arundhati Dasgupta, consultant endocrinology, Siliguri, director and consultant endocrinologist from Siliguri, course coordinator, PHFI courses, and several other national and regional training program. several national and international publication madam is having, and authors of several chapters in many books. So with this, now I request Sir Dr. Fisher to start his presentation. Thank you, sir.
Thank you very much for that very kind introduction. Now, I'm very much a clinician. So although I've done a lot of research and a lot of educational things in the past, until last year, I was also doing 3 clinics a week, 1 in type 1 diabetes, 2 clinics for people with type 2 diabetes, and a thyroid clinic. So I'm speaking to you very much from a practical point of view, with extensive use of SGLT2 inhibitors, everything through from early in therapy in addition to metformin, through to patients who have had it added to insulin therapy. These are my disclosures. I've worked with many pharmaceutical companies. I have a particular interest, as I'll show you, in heart disease and diabetes. And so I've always been interested in any new therapy for diabetes to see if it gives any benefits for cardiac outcomes. And as we'll see extensively for SGLT2 inhibitors, that is the case. Now, a long time ago, 1996 in Dublin, heart disease was really very much not a thing that people were very worried about in diabetes. All of the research and clinical focus was on blindness and renal failure. And I gave this talk, and it's the old-fashioned blue slide, to try and get people to remember that although blindness and renal failure are clinically extremely important, it's actually cardiac disease that killed our patients. So I redefined diabetes very starkly as a state of premature cardiovascular death associated with chronic hyperglycemia, may also be associated with blindness and renal failure if our patients lived long enough, because of course many patients still die from a heart attack before their kidneys fail or before they go blind. Now, is it still a state of premature cardiovascular death? The short answer is yes. So this is international data from the Emerging Risk Factors Collaboration in 2010. Coronary disease, stroke disease, vascular deaths are doubled in people with diabetes compared to non-diabetic people from the corresponding populations. But actually, although doubling sounds terrible, this is a great improvement, because heart disease deaths used to be increased 4-fold in people with diabetes compared to non-diabetic people. Now, this is some data from Sweden, where everyone with diabetes is on a register. And whether you look at top left, death from any cause, death from cardiovascular disease, death from coronary disease, or hospitalization, in blue, patients with type 2 diabetes, we are seeing a gradual improvement and a reduction in coronary heart disease. Now, why is that? Well, that's because we now aggressively treat blood pressure with ACE inhibitors and ARBs, and we give most of our patients statins. So the atherosclerotic disease is becoming less. Now, this is a cohort data from United Kingdom. As atherosclerotic disease becomes less, then heart failure becomes a commoner problem in clinical diabetes. And so this is the first presenting coronary event in people with type 2 diabetes, because heart failure has multiple drivers, not just atherosclerosis, but hypertension. People with diabetes get a stiff ventricle that doesn't relax so well, and I'll come back to that. Now, if we think of ways of reducing heart disease, blood pressure to the right and cholesterol in the middle have a very steep slope, whereas actually treating blood sugar from an epidemiological point of view, we wouldn't expect per se there to be great reductions in atherosclerotic events. And that indeed is what we saw in the trials. So this is a meta-analysis of the intensive trials, ACCORD, done in America, ADVANCE we took part in our centre in Scotland, UK PDS, again, a study done in the United Kingdom. In all of these, there was phenomenal reductions in microvascular disease, But overall, the reduction in macrovascular disease, disappointing. So yes, a significant reduction in myocardial infarction, but overall no reduction in cardiovascular death. Now these studies were done in the times of what I'm calling older drugs. So the intensive treatment was around metformin, sulfonylureas, acarbose, glitazones, and insulin. Therapies which are still commonly used throughout the world and commonly used in India. But in none of these trials was there use of the newer drugs, and the newer drugs fall into three classes: the DPP4 inhibitors called gliptins, the SGLT2 inhibitors called gliflozins, and the GLP-1 receptor agonists, which usually are something tight. And until recently, GLP-1 receptor agonists were all injected therapies, whereas the other two are oral treatments. Now we have to thank a cardiologist called Steve Nissen, because Steve Nissen was analyzing the data from rosiglitazone and identified that rosiglitazone actually increased or seemed to increase non-fatal myocardial infarction. And as a consequence of that, to get a license in the United States and Europe, all of these newer therapies for diabetes had to have a much more detailed cardiovascular assessment for safety and then potentially for benefit. And that's where we have all this fantastic data on SGLT2 inhibitors. So they indicated between 2008 and 2020 that you have a development program that's rich in high-risk patients, and at some point you do a dedicated cardiovascular outcome trial. Now, there have been lots and lots of these, but the great advantage here we see just SGLT2 inhibitors is that each year we have additional information. So we now have been able to analyze and to think about the outcomes from these trials, and each new study that comes along, we have the chance of seeing how it compares to previous trials. Now, from a mechanistic point of view, the SGLT2 inhibitors stop or reduce reabsorption of glucose in the proximal convoluted tubule, and they force glycosuria. Because they force glycosuria, your HbA1c improves, and they are moderately effective treatments at getting down your HbA1c. Because you're forcing glycosuria, you increase calorie loss and you lose weight. And for patients who are trying to lose weight, this is a very attractive associated feature. Many of my patients have been trying for a very long time to get the weight down, and they haven't succeeded. So if you give them a tablet and they start losing weight, they're likely to keep going with that tablet. They have a very slight osmotic diuresis, and that, along with several other factors, reduces blood pressure. So the benefits are reducing HbA1c, reducing your weight, and reducing your blood pressure. Now, before the trials were completed, I was doing a presentation 6 years ago at a spring meeting of the Association of British Clinical Diabetologists. And I was asked to predict what would happen with the trials. And for EMPA-REG outcome, which was the first result we got with empagliflozin, I predicted, this was before the study was finished, there would be a reduction in MACE, and we would be arguing over whether it was just related to blood pressure. Now, I was partly right because there was a reduction in MACE, but I wasn't aware of how great the reduction was going to be in all the events and how great the reduction was going to be across the class and in people who didn't have diabetes. And I'm going to talk about each of these things in a bit more detail. So this, I've said, is key paper number 1, presented and published in 2015. All of the people in this trial had existing atherosclerosis and type 2 diabetes. They were given empagliflozin or placebo. Top left, MACE was significantly reduced. But the stunning thing was overall deaths from cardiovascular disease were reduced and reduced early. All-cause mortality was reduced. And then the unexpected one, which really interested cardiologists, was hospitalization for heart failure was both reduced and reduced early. And we'll come back to that. So this was the first of the trials. Since then, we've had a subsequently 3 other outcome trials in people with diabetes. The canagliflozin trial was a similar trial to the empagliflozin trial, but unexpectedly showed an increase in fractures and amputations. I'll talk a bit more about the dapagliflozin trial because it extended the information we had. And then ertugliflozin, the most recent trial, was actually very disappointing because it didn't give any clear benefit. So if there is a class effect of these drugs, then I would suggest to you the class effect does not include ertugliflozin. So in canvas, an increase in amputations and an increase in fractures that has not been seen with any of the other drugs in any of the other trials. So the DECLARE TIMI trial, it was slightly different from the empagliflozin trial. The majority of people in this trial did not have existing vascular disease, but were at increased risk. So that was the one difference. And then the second difference was rather than having MACE as the primary outcome, this trial had 2 primary outcomes, a heart failure one and a MACE one. Now, the important thing is the heart failure benefit was overwhelming and substantial. There was also a reduction in a renal composite. Top right, MACE was numerically reduced, but overall was not significantly reduced. And I'll come back to that in the next 2 slides. And overall, although there was a trend for improvement in all-cause mortality, again, because this was a lower risk group, that did not reach statistical significance. Now, because a lot of the people in this trial had high risk, but they did not have existing vascular disease, a pre-specified analysis was people that went into the trial with a prior MI. Now, they were slightly different. They were a wee bit older, a bit more smokers, as you might expect, a bit more dyslipidemia. But the important thing is here that just like in the empagliflozin trial, where everyone had atherosclerosis, in the DECLARE TIMI trial, if you entered the trial with a prior MI, at the top here, you had a highly statistically significant reduction in further MACE events. Now, the VERTUS trial, as I said, was disappointing. This was the trial with ertugliflozin, and it didn't have benefits in MACE. In the chosen renal composite, it didn't have benefits. The only benefit that was seen with this was in hospitalization for heart failure. Now, putting it together, we can see this kind of diagram or cartoon, whereas whether you've got established atherosclerosis or multiple risk factors, you seem to get renal protection, I say, except with ertugliflozin. You seem to have reductions in hospitalization for heart failure, but you only have reduction in MACE if you already have existing MACE. Now, this is key paper number 2. I was present when this trial was designed. So following the EMPA-REG outcome results, a group of cardiologists, diabetologists, nephrologists was pulled together because the heart failure benefit seemed to be a very early one. And so the question was, could this heart failure benefit apply to people with existing and well-documented heart failure? And could it apply to people who did not have diabetes? And the answer to both of these questions is yes. So all these patients had heart failure with a reduced ejection fraction. The composite chosen was a heart failure one, heart failure death, heart failure hospitalization, urgent hospital visit, or cardiovascular death. Highly significant reduction in these events. And there were reductions whether you had diabetes or you didn't have diabetes. And that's how these drugs are now, how dapagliflozin in particular is now embedded in heart failure therapies. Now, in diabetes, quite a lot of heart failure is people who have heart failure with a preserved ejection fraction. They were not studied in this trial, but a trial is ongoing. The trial is called DELIVER, and we should get the results of DELIVER at the end of this year. So by the end of this year, we'll have information on whether patients who have heart failure with a preserved ejection fraction, whether they benefit as well from this class of drugs. The other heart failure trial, which followed on a year later from the dapagliflozin trial, was the empagliflozin trial, a significant reduction in the composite outcome of cardiovascular death, hospitalization for heart failure, and overall similar benefits, but perhaps just not quite so striking as in the dapagliflozin trial. So the heart failure trials we've got with dapagliflozin, empagliflozin. We also have a trial with a drug called sotagliflozin. Now, sotagliflozin is not a drug that's been used clinically. I was involved with events adjudication in the phase 3 development program. It was being developed by Sanofi, but Sanofi gave up development of that drug. So it may be a drug that will have research information, but actually never gets used clinically. But we see there was reductions with dapagliflozin in cardiovascular death, worsening heart failure, all-cause mortality, cardiovascular death, and also a renal composite. So across the board benefits, I say, regardless of whether you did or did not have diabetes. And if you had benefits in people without diabetes, they didn't have changes in HbA1c. So that also tells us the benefit has nothing to do with reducing your HbA1c. Now, if we now turn to the renal effects, when you give an SGLT2 inhibitor, this is the empagliflozin data. Initially, you have a very slight reduction in eGFR, which then stabilizes out. And in this trial, it was 2 different doses. The eGFR in non-treated people steadily falls in people with diabetes. So the ability ACE inhibitors with an SGLT2 inhibitor, an initial fall, which then halts the decline. Now, in the diabetes trials, there were renal composite outcomes, and in the 3 positive ones, these were all reduced. Again, with ertugliflozin, their composite wasn't reduced, although a revised composite was reduced. Again, these were all trials in people with diabetes, and the renal was a secondary outcome. So to try and get further information, a trial was done in patients with diabetes and CKD. This trial was called Credence, and it was looking at patients who had established diabetic nephropathy to see if their nephropathy progressed. And there was a significant reduction with canagliflozin. But I've said that the dapagliflozin trial to me is the third key paper, because just like the heart failure trial, this trial was in people with CKD, whether they had diabetes or not. So it's much more widely applicable. And in this, dapagliflozin reduced renal progression, renal events in people with chronic kidney disease. So the primary composite outcome in dapagliflozin, nearly a 39% reduction compared to the placebo group. And again, dapagliflozin is now, in some parts of the world, I'll show you, has a license and it's been integrated into guidelines for patients with CKD, regardless of whether they have diabetes or not. So the renal trials, Credence was in diabetic people. The dapagliflozin trial included diabetes, but also non-diabetic people. Again, only in people with diabetes. There was a trial with this drug that we don't have called sotagliflozin. What about empagliflozin? Well, there is a trial running called EMPA-Kidney, but that one we won't get the results of until 2022. So just now, the only drug that has a data for the non-diabetic population is dapagliflozin. Now, international licensing, dapagliflozin got an approval for diabetes in type 2 in 2012. In the EU, it also got approval at a lower dose for people with type 1 in 2019. With regards to diabetic kidney disease, canagliflozin was first approved in the United States, followed by EU. And then for heart failure, just the same, dapagliflozin was approved in the United States first, and then at the end of 2020, or the middle of 2020, was again approved in the EU. And then we've just got information that for CKD, so that's wider than diabetes, again, dapagliflozin has been approved in the United States, and we are anticipating approval in the EU and in the United Kingdom, which of course has now left the EU. We're anticipating that will come possibly even this month, if not next month. So these drugs are not just shown in scientific outcome trials, but are now licensed for these indications. And this is just a diabetes guideline. It's the ADA-EASD consensus report. And basically it says, metformin, they recommend, is still first line, but thereafter, if you've got heart failure or got atherosclerosis or you're at high risk, you want to strongly consider either an SGLT2 inhibitor, and I've shown you all the data for that, or if it's atherosclerosis, you might consider a GLP-1 receptor agonist. To emphasize at this point, GLP-1 receptor agonists, they do reduce atherosclerotic events, but it's only in people with diabetes. They don't reduce heart failure events, they don't reduce CKD, and they have no evidence for benefit in the non-diabetic population. Similarly, DPP-4 inhibitors in diabetes are entirely neutral. They're weight neutral. They have no effects on progression of atherosclerosis. They have no effects on heart failure. In fact, a couple of them may actually worsen heart failure. They're easy to use, and in fact, they're quite widely used. But whenever you see a patient in clinical practice that's already on a DPP-4 inhibitor, I suggest you want to consider whether the patient would be better switching to an SGLT2 inhibitor. And then here, as I talked about, if the patient wants to lose weight or there's a compelling medical reason to lose weight, say, for example, they've got sleep apnea, then SGLT2 inhibitors are the drugs you want to use. And if they're already on a DPP-4 inhibitor, again, you want to consider whether switching them to that would be of benefit. I'll just go here. Now, one of the questions that comes up frequently is what is the mechanism of benefit? Along with a cardiology colleague from London called Martin Cowan, we looked at this extensively in 2020, and we completed a review for the journal called Nature Review Cardiology. The short answer is we don't know. We identified over 30 different factors, all of which went in the right direction. But we concluded that whatever it was largely independent of improvements in sugar because of these benefits that we're seeing in the non-diabetic population. And to think about it simply, we would suggest it's all to do with sodium handling. By handling sodium in a much more physiological way, it improves the way the kidneys function. At the same time, we are removing sodium with water in places that it's not wanted, and so we're improving heart failure outcomes as well. And there are many, many reviews on this, and also many, many mechanistic trials are running just now because the trials were looking at safety and or benefit, but not what the mechanism of benefit might be. And again, I say there are over 30 different mechanisms whereby SGLT2 inhibitors may improve either heart outcomes or kidney outcomes or both. Now, what about safety? Well, the commonest side effect that we see in clinical practice is an increase in genital fungal infections, and that is something that we might anticipate. We also see further up here a slight increase in ketoacidosis. Now, you see it was 0.1% in the placebo group because ketoacidosis is a relatively uncommon occurrence in people with type 2 diabetes, but it is increased with SGLT2 inhibitors. By far much more common is genital fungal infections. So what have we learned from these outcome trials? Well, if you've got atherosclerosis and diabetes, SGLT2 inhibitors will reduce that. If you've got heart failure, or if you've got diabetes and existing atherosclerosis, or if you've got diabetes and high risk, heart failure events will be reduced. We also know SGLT2 inhibitors reduce renal events, both in people with diabetes and also in people with CKD. So these are not just diabetes drugs now, they are heart failure drugs and they're kidney failure drugs. They are moderately effective at reducing HbA1c, but just remember, if you're going to use them in a diabetic person for their renal protection reasons, anticipate the drop in HbA1c will be less because they work through your kidneys. And then you're predominantly giving them for renal outcomes. The genitourinary side effects are the commonest ones. So you want to advise patients about genital hygiene and about the fact that if they get thrush, it will respond to the usual measures. And there is a slight increase in the risk of ketoacidosis. And so patients need to be educated about what we call sick day rules, that SGLT2 inhibitors, along with metformin, ACE inhibitors, ARBs, are drugs that patients should be advised to discontinue during episodes of acute illness. And then when over the acute illness, then they restart all these medications. Now, one of the things is we in diabetes have lots of hands-on experience with these drugs. Can we help our cardiology and diabetes colleagues? The answer is yes. They will need to identify patients with diabetes. They'll need to classify them, because still we're going to have to be very cautious about using SGLT2 inhibitors in people with type 1 or pancreatic diabetes. That we need to have pathways for patients who are already on sulfonylureas or insulin, because if you add in an SGLT2, you're going to have a risk of either hypoglycemia, and also we need to have pathways for patients to reduce the risk of ketoacidosis. So very much cardiologists, diabetologists, kidney doctors are now going to have to work together so we can benefit broadly our patients. So I redefined my definition of diabetes for a meeting earlier this year. I said now that diabetes is a state of premature cardiovascular death associated with chronic hyperglycemia, may also be associated with cardiovascular disease and renal disease, and SGLT2 inhibitors are the only class of drugs that reduce all three of these outcomes. That's heart failure outcomes, cardiovascular outcomes, renal outcomes, and also premature death. If you want to get further information, I did co-author a book on this. It's now a wee bit out of date. We have just, however, done an online module for the British Journal of Cardiology, which is completely up to date. And we are currently writing and co-editing a much wider book on diabetes drug notes for John Wiley Publisher, which will be available internationally, and it will be available either at the end of this year or early next year. And I am currently writing the chapter on SGLT2 inhibitors. So it will be bang up to date. It will include the new information on dapagliflozin from the DECLARE trial, which we'll get towards the end of this year. Thank you for your attention.
Thank you so much, Professor Fisher. I think, Professor Fisher set the ball rolling in a very fascinating way. The slide that he showed about the number of drugs that are available for managing diabetes. The armamentarium for managing diabetes has steeply increased in the last 2 decades. And fundamentally, I remember those sulfonylurea days, and particularly the younger generation must not have seen much of drugs like chlorpropamide, which used to have a half-life of 72 hours. And if a person would get hypoglycemia, you had to hospitalize him. It could last for days together. But many of you might have seen glibenclamide. And for a good part of a century, I would say for half a decade, more than half a decade, the only sulfonylurea, the only oral drugs available were sulfonylureas. We in the Indian subcontinent were fortunate that metformin was available to us for a good part of 30, 40 years, which Western world was deprived of till early 90s. Whatever our administrative inactions, at least one area where that administrative inaction benefited, and the world emulated thereafter.
Can I just say, metformin has been available in the United Kingdom for 64 years. So metformin was always available, and quite a lot of the early stuff was done in Scotland, in Edinburgh. Yeah, but it's America.
When, in mid-60s, this was banned, particularly in the Western world. And we did not take cognizance of that. In fact, we continued using fenformin also till it went off the market. And the last paper on fenformin is from our group. When you have fenformin failure, what next? But, when gliptins came in, it was a huge relief for Professor Fisher, for diabetologist community, endocrinologists, because we had been so plagued by these hypoglycemias, because those primitive insulins, those long-acting sulfonylureas would make it very difficult to optimize diabetes treatment. Why, one, that manpower was not available in the country in a huge way. Not that it is available now, but it was it is much better today than it was when I started endocrine practice. When gliptins came to the fore, it was a huge relief that slowly and steadily hypoglycemia started becoming lesser. And many times I remember hordes of people, whom we put on insulin, those Lent insulin, NPHs, regular insulins, and MSIs and all that. I say, okay, fine, your HbA1c has dropped down from 9.5 to 7.8. Great, because we never visualized it could come down to 6.8 in 80s. Could never visualize it. But suddenly you will realize this guy who was 82 kilos has become 88 kilos. And, so gliptins made a huge difference. And when the word about SGLT2s came in, I must tell you honestly, many of us in the Indian subcontinent were skeptical. Skeptical because of, one, whatever data had emerged in terms of infections, either genital infections or urinary tract infections, what other numerically less infections were there, because we see a lot of infections in this part of the world. And in fact, my group published a paper in 1999. It was a 10 years mortality data, which shows that in diabetics, the #1 killer is infections. So as an individual was damn skeptical. And we had replicated this data on mortality, which initially we published in 1999. Then another 10 years data in 2009. We showed that diabetics in India were living longer. The gap between diabetic and non-diabetic population was shrinking. But infections still continued to be #1 killers. And renal disease was #2 killer, because we could never optimize that HbA1c. Now, why people were living longer now? Because not that the diabetes management were getting optimal, because more and more we used to use ACE inhibitors, ARBs, statins. So overall longevity improved, and many people got trained in the country, so manpower to handle diabetes increased. Not proportionate to the demand, but marginally better than what it used to be decades earlier. But time has shown that chosen patients properly, these infections in 90% people are not a problem. I'm saying my own clinical understanding after using these SGLT2 inhibitors for quite some time now. See, you need to choose your patients initially rightly, that they don't have any overt infection. Treat them properly, particularly females, particularly people who have some predisposition. Euglycemic ketoacidosis in the initial era too, a lot of noise was created globally as well as across the country. But I don't think, people got educated very early, and we could anticipate those insulinopenic patients, so-called thin, lean type 2 diabetics, where there was always a potentiality of making an error between a lean type 2 diabetic and latent autoimmune diabetes of the adult. And then a person having a concomitant comorbidity which would predispose him to diabetic ketoacidosis. I don't think any major disasters have happened in the last half a decade. Initially, a few cases were known, but now, as Professor Fisher very rightly was saying, if you have an acute sickness, if you are subjected to surgery, if you have a trauma, take off this drug and give a treatment that is given for acute care anywhere in the world that we have been practicing for a long time, that we are good at, because we see a lot of critical and acute sickness in this part of the world. Then mostly, Indian market and Indian patient is cost sensitive. You see, when you look at, I see India is a bipolar country. We have a 20 crore population, that is United States and Britain. And we have 120 crore people that economically a totally different ballgame. So whenever we talk about increase in use of drugs that are costly, everything sells in India because there's a market for everything. We have a more than one European country in any economic bracket, in educational bracket. So, that's how, sulfonylurea still, I think, more than 2/3 of people still use them, in spite of the fact that gliptins now have been in the market for a good part of a decade. Cheaper gliptins are available. But unfortunately, benefits of these SGLT2 inhibitors, which unambiguously Professor Fisher talked about, we have empty number of times Professor Fisher talked about the cardiac benefits. And all national forums ad libitum in the last half a decade, right from Empiric of 2015 till the current data and DAPA heart failure and DAPA CKD, everything teased. But one time we have a class of molecule that not only controls diabetes, may or may not optimally control diabetes, but whatever damage the diabetes does or the hyperglycemia does, it has a potential of changing the natural history of those complications. So at the end of the day, whenever you treat a disorder, what are we looking at? What morbidity you get, what mortality you get. And if those things are in a big way taken care of, then probably if we reduce those cardiovascular events, if we reduce cardiovascular death, if we reduce all-cause mortality, if we reduce the chances of hospitalization for heart failure. Now, DAPA CKD showed a 39% reduction in hard endpoints, whether it is reversal of microproteinuria, reduction of macroproteinuria, or retention of eGFR at a much higher level in comparison to a comparator arm, or a significant reduction in people who need kidney replacement therapy, either in the form of dialysis and in the form of a renal transplant. And it is a big thing for a nation like India, which is a population of 77 million diabetics. And while diabetes in big chunk of people is not optimally managed, where hemoglobin A1C is hardly controlled in 1/4. And preventing this CKD is going to be a huge thing, because managing diabetes may be difficult, but is still manageable, costly, not that costly. Even managing a coronary artery disease, putting in a stent, even a CBG one-time effort. But maintaining for years and years a renal replacement therapy for an Indian population is a huge thing. So that's where probably this new class of drugs comes. So we have been waiting when the costs would go down, at least one factor would go down in managing this thing. We'll be now discussing a few clinical scenarios, and some of my very senior bright colleagues will be taking care of it. Now I would request Professor Bobby Matthews to present his first case. Then we'll have a brief discussion for a couple of minutes, and we'll move on to the other two cases. And then at the fag end, we'll be discussing some issues with Professor Fisher. Over to Dr. Matthews. Please share your screen. You unmute, Bobby. You unmute.
Sir, please unmute.
There's that button on the right, lower left side.
Can you hear me, sir, now?
Yeah. Okay, fine, perfect.
So I have a case discussion, a case discussion on dapagliflozin with respect to heart failure and CRF. But this slide is the basic slide. This will be going. I have only 7 minutes. I'll be expanding. A 65-year-old male suffering from type 2 diabetes since more than 10 years. Presented to the clinic for routine follow-up for management of diabetes. He was initially on metformin 500 mg BD and linagliptin 5 mg once daily. A 60-year-old person with type 2 diabetes of 10 years duration, still underdosed on metformin. So optimal dose of metformin is GFR is more than 45, is 1 gram BD. The patient is just on 500 mg, but he's on a gliptin also. We know that the renal friendly and hepatic friendly gliptin is nothing but linagliptin. Irrespective of LFT, RFT, you can give a linagliptin. He is obese with a body weight of 92 kg. His BMI is 31.8. So Indian or Asian phenotype is a thin, obese Asian phenotype. A BMI more than 23 is the cutoff for overweight, 25 is the cutoff for obesity. So roughly speaking, a type 2 diabetes obese person with grade 2 obesity with an HbA1c of 8.1 who is on metformin 1 gram with linagliptin 5 mg. He is also suffering from hypertension. We know a classical scenario that is in metabolic syndrome or type 2 diabetes, which Sir was telling initially itself. Type 1 diabetes is a glucose-centric phenomenon. Type 2 diabetes is a metabolic-centric phenomenon. That's why 70% of type 2 die of nothing but a coronary artery disease. So all the three components, A, B, C, HbA1c less than 7, BP less than 130 by 80, and the LDL should be less than 70. This person is having a BMI more than 23 with an HbA1c 8.1, so that should be less than 7. He's suffering from hypertension. He's done an echo. Echo shows an ejection fraction less than 45%. So as evidence, we know that Sir was telling 65% of the people with diabetes at the end of 5 years have some form of heart failure. This is a heart failure with a reduced ejection fraction. He has a baseline fasting blood sugar post-pandemic, both high, and HbA1c level was 8.1. Patient is highly non-compliant with injectable drugs and insulin. So that means that there is no option. He's not going for injectables or GLP-1 analog, exenatide, dietide, liraglutide, dulaglutide, or Ozempic. Patient is not going to take. He was on other medication for hypertension. He's on telmisartan, amlodipine. For cholesterol, he's on atorvastatin and hydrochlorothiazide. So all this, you know, invariably the reply for this question. So I'll be just discussing with this slides because I have only 7 minutes for me. So basically, he's a type 2 diabetes obese person who is on metformin 1 gram with linagliptin 5 milligram with HbA1c 8.1. He's a classical person with a metabolic syndrome phenotype with a BP and cholesterol. For BP, he's taking atorvastatin. We don't know the value of LDL, but we know statins at 40, age more than 40. Every diabetic patient should take a modest intensity statin. That means that a rosuvastatin of 5 or atorvastatin of 10. His dose of atorvastatin is not given, so he should be on an atorvastatin 10 or 20 to keep his LDL less than 70. So his BP, he's already on a telmisartan, amlodipine. So we know the ADA guidelines, grade 2 hypertension presenting with BP more than 160 by 100 should be on a dual therapy, ACE or ARB with a dihydropyridine calcium channel blocker. So invariably, now the dihydropyridine calcium channel blocker, some people many times we give amlodipine, some people like cilindipine, acylindipine, benzodiazepine, LTN, ABCD, all the channels are getting blocked. But invariably, dihydropyridine calcium channel blocker with maximum hypertension reduction and maximum trials for cardioprotection, nephroprotection is still now for amlodipine only. And this patient is on hydrochlorothiazide. We know hydrochlorothiazide is no longer used. It has been converted to chlorthalidone, thiazide-like diuretic chlorthalidone. So coming to the point of view, BP should be controlled with the telmisartan. The BP value is not given. LDL should be controlled with a statin. Hydrochlorothiazide, we are not believing. We should convert it to a chlorthalidone. And what about sugar control? That we have no other way. He is a type 2 diabetes, obese person, uncontrolled on metformin monotherapy with documented atherosclerotic cardiovascular disease. Any person, just like Sir was telling. So next slide, I should go to. So this is the guidelines that I was discussing. Any patient where metformin 1 gram BD fails with documented atherosclerotic cardiovascular disease, you have to go for an SGLT2 inhibitor or a GLP-1 analog. With atherosclerotic cardiovascular disease, patient with failures, patient with ejection fraction less than 45% or a macroalbuminuria, the GFR more than 30, you have to be the first option to an SGLT2 inhibitor, then only GLP-1 analog. So our patient is very clear. He's a type 2 diabetes, obese person with documented atherosclerotic cardiovascular with an echo showing an ejection fraction less than 45%, with a macroalbuminuria, with a GFR more than 30. You have no other option. You have to go for nothing but an SGLT2 inhibitor. It can be a DAPA, CANA, EMBA, whatever. So what is the HbA1c control you are going to get with an, what is the HbA1c control that you are going to get with the addition of an SGLT2 inhibitor? We know that monotherapy with dapagliflozin add on to metformin, sulfonylurea, insulin, everything you get an HbA1c reduction of 0.9 gram percentage. So this person, metformin 1 gram, linagliptin 5 milligram, creatinine is not given, but GFR is more than 50. What will you or may do? Nothing. We will increase the dose of metformin anyway to 1 gram BD. We will add an SGLT2 inhibitor, dapagliflozin. Metformin 1 gram itself will reduce HbA1c by 0.5 gram percentage. Adding on a dapagliflozin or a dapanom will again HbA1c reduction by 0.9 gram percentage. We are bound to get an HbA1c reduction less than 7 gram percentage. Look at the right hand of the slide. Patient, metformin 1 gram BD fails with no documented atherosclerotic cardiovascular. Suppose this patient was telling, doctor, I did a TMD, that is normal. I did an echo, that was perfectly normal. My ejection fraction is more than 60%. So person who is obese with no documented atherosclerotic cardiovascular, then also if weight loss was a concern for him, I would have written nothing but a dapagliflozin, CANA or EMBA. I can never go for a liraglutide Victoza because this patient doesn't want an injectable therapy. Look at other Indian scenario. A scenario 3 months back or 6 months back before dapagliflozin, they reduced the price in India. Before it was 57 rupees for all glyphosate. Now it is 10 or 16 rupees. So about that scenario, this patient is coming to my OPD in Kerala and telling, doctor, I'm metformin 1 gram BD. That is not problem for cost for me. I can spend 5 rupees. I'm on linagliptin. That's cost me 55 rupees. Now I'm not having cardiac disease, doctor. I did a TMD and another doctor has asked me to write a dapagliflozin. I can't afford 57 rupees for that. So what drug should I go for? Then in that condition with no documented atherosclerotic cardiovascular, I can't go for a gliptin because this patient is already on a gliptin. So I can go for a sulfonylurea or a pioglitazone. That's why I wanted to touch the point of pioglitazone also. Pioglitazone, which was midst of controversy with all the bladder cancer, all the history of Nissen's meta-analysis, came with a boom in 2016. Now we know the only anti-diabetic drug which can cause significant stroke reduction by reducing carotid intermediate thickness is no longer any other drug. It is pioglitazone. So this patient, taking in a whole, according to whatever case history system, he's having atherosclerotic cardiovascular disease with heart failure, ejection fraction less than 45%, macroalbuminuria, I should go for an SGLT2 inhibitor. Suppose case 2, if he's having no documented atherosclerotic cardiovascular disease where he can't afford for an SGLT2 inhibitor, he don't want a hypoglycemia, then I will go for nothing but a pioglitazone, provided he doesn't have a cardiac failure or say echo is normal. Now going to the next slide. So 2 more minutes only for me. So SGLT2 inhibitor we know, and all the other slides everyone has presented. But one more thing I wanted to, hypertension, diabetes, because this is the scenario we know. DAPAC CKD study has taught us that the only single drug other than ACE or ARB which can prevent the progression of nephropathy in a patient with CRF with or without diabetes with a GFR less than 30 or more than 30 other than ACE or ARB is SGLT2 inhibitor. That is why now the approval is given for patients with CRF with or without diabetes to prevent the progression of nephropathy. But the first drug still remains ACE and ARB, time and tide tested proven. That is why many of the times we see, today also I saw a patient, I am just a person practicing for this 14 or 15 years, a senior physician writing a person on losartan 100 milligram. The patient had a very bad macroalbuminuria. He was very well controlled with hypertension with the losartan 100 milligram and the macroalbuminuria getting controlled. But the moment the creatinine became 1.6, he went to a nephrologist. Potassium was just 4.2. Nephrologist cutting the losartan and putting a saline between 10 milligram and sending the patient off, sending the wrong signal to the patients and the doctors, treating physicians' brain that ACE and ARB should not be given in patients with high creatinine. That's why I put this slide. We know that what are the absolute contraindications for AC and ARB, losartan, telmisartan, olmesartan, asilsartan. It is bilateral renal artery stenosis, pregnancy, hyperkalemia. So always mind it, bilateral renal artery stenosis don't give pregnancy, hyperkalemia. No matter how much high your creatinine is 5, 10, 15 or 20, the first line drug for diabetes with hypertension or diabetes with CRF is ACE or ARB, because how much ever high the creatinine is, if your potassium is less than 5.5, it always prolongs the creatinine, doubling the main, reducing the intraglomerular hypertension. It reduces the glomerular sclerosis and renal scarring by reducing the aldosterone level. So ACE and ARB is the first cornerstone. This patient is already on telmisartan, amlodipine, hydrocortisone, we should be out. But look at the potassium, don't look at the creatinine, because many times we see the same phenomenon. And not writing on a statin, we know in our country, many people never used to say statin. People used to think that eating contributes to cholesterol. Now all the guidelines tell us that only 10% of cholesterol is controlled by the food, 85% is controlled by the liver. So the rule of statin set for you may be vegetarian, you may be Brahmin, you may be going to Shabarimala, going the fast. Still people tell that I am on a Lent or a fast. Why should you take a statin? Nothing. Statin set 40, age more than 40. So nephroprotection, cardioprotection is offered by SGLT2. Okay. But nephroprotection, cardioprotection is offered by diet exercise. It is offered by statin. It is offered by your thiamine, losartan, telmisartan, olmesartan. Now coming to the second last slide, which I have to tell to you. So hypertension, diabetes, what are the indications for AC inhibitor, ARB? We know what are the indications for SGLT inhibitor, DAPA, CANA. Because this slide itself, I got it more clear because of this presentation. I was reading it. Otherwise, we all know, sometimes we know, previously 5 years back, endocrinologist only used to write DAPA, CANA. 3 years back, we know all the DAPA heart failure, not the DAPA heart failure, DAPA cardiovascular exclusion game, we know the cardiologist started writing. Now, for the past 1 year, we see nephrologists writing SGLT2 just like anything, even a DAPA glyphosine 5 milligram with many of the prescriptions. So that takes us to that DAPA glyphosine or glyphosine came as a drug for HbA1c control with probable nephroprotection, cardioprotection with a weight loss with no hypoglycemia. Now it is more or less converted to a drug for heart failure or for CRF with probably extra cardiac, extra nephro benefit of an HbA1c control. So a drug which was only used by endocrinologists, now it is almost 80% used by a cardiologist and nephrologist and probably for diabetic control. So probably with the time going on, we may think that it's a poor glycemic control agent, but for a better agent for controlling the nephropathy and the cardiac failure. Now this is the last slide. So what are the approved indications for treatment for SGLT2 inhibitor? Monotherapy in type 2 diabetes, add-on therapy with metformin in patients with atherosclerotic cardiovascular disease, especially CRF and CCF, first-line therapy in patients with heart failure with reduced ejection fraction, and fourth and most important, the first-line therapy in patients with CRF along with ACE and ARB, CRF with or without diabetes with a GFR less than 30 or more than 30 for prevention of progression of nephropathy. Because many times in contraindication for SGLT2, we write type 1 diabetes, pregnancy, lactation, GFR less than 30. GFR less than 30 is not a contraindication like metformin. GFR less than 30 is put as a contraindication for dapagliflozin because your glycemic control of SGLT2 inhibitor depends upon your GFR. As your GFR becomes less than 30, as Fisher sir has told, your glycemic control becomes near zero, but your nephroprotection still continues. So you can continue a process with the dapagliflozin of 10 for your nephroprotection. For your glycemic control, you can put a basal insulin, you can go for linagliptin. So this is the case study. So this is the last thing. So basically the uric acid point also I want to touch with that, because metabolic syndrome, previously uric acid was already treated with gout. People used to think that, we all used to, on MBBS days used to think that only 5% of people with high uric acid develop a gout. So asymptomatic hyperuricemia was never treated. Now we know uric acid is no longer treated for gouty arthritis, gouty tophy or gouty nephrolithiasis. Uric acid is a direct risk factor for coronary disease, hypertension and worsening of nephropathy. So HbA1c control is important for type 1 diabetes, but type 2 diabetes is nothing but cardiac control, metabolic control, and infection control. So for HbA1c control is important, BP control, LDL control, and uric acid control. But after metformin, what we know, invariably 80% of atherosclerotic silent disease, you have to go for an SGLT2 inhibitor. In people who are willing for an injectable, you can go for a GLP-1 analog, especially in people with atherosclerosis predominant, GLP-1 analog, failure predominant, always an SGLT2 inhibitor. This is the case study, sir. With that, I'm finishing. Thank you, sir.
Thank you, Bobby. I think, you can unshare it. A couple of things that we need to discuss here. One, our patient's HbA1c was 8.1, and we anticipate that if we give our SGLT2 inhibitors well, we would expect another 0.7, 0.8, so might come down to 7.5, obviously much better than where he stands today. Now, there is another scenario. Now, this fellow's HbA1c is 7.2 already. All right, and his EGFR has dropped, and EGFR drop, we don't have to wait to treat it to make it more than 30. I'm just like, you don't have to wait necessarily. These are clinical trial deadlines. But if somebody already has an EGFR in a relatively, it's not a very old man, an elderly person, 45 is already significantly reduced. He would already qualify already for a chronic renal dysfunction. So if his diabetes is very well controlled with the drugs that you are giving him, let's say that he already has a 7.2, 6.8 hemoglobin A1c, but his EGFR is 45. Does he justify, would you still add an SGLT2 inhibitor or not? Because if it's 8.1, we want to optimize it to lower, is understandable if there is no overt contraindication. But now a scenario that he comes to you to 7.2 or 6.8, but you find out his EGFR is a bit dicey. The way you talked about your patient on losartan with 1.6, before he goes to 1.6, he should have been treated better at 1.2. Right. So what would be your decision on this? You are again muted. Bobby, you are muted.
Okay, sir, talking by the guidelines, any patient with documented atherosclerotic cardiovascular disease, irrespective of baseline HbA1c and target HbA1c, you have to go for an SGLT2 inhibitor or a GLP-1 analog. So the patient is not on metformin baseline.
So the point is that even if his diabetes was well controlled and he was dropping his EGFR, you would still try to incorporate an
SGLT2 inhibitor. But if suppose, sir, second scenario, if you are telling that his GFR is falling down, his HbA1c is 8.2, will you still put for a glycemic control? But when GFR comes down less than 45 or less than 30, my glycemic control on SGLT2 inhibitor becomes minimally and it becomes poor. So I'll be putting that for nephroprotection or cardioprotection.
One important thing I want to emphasize on my colleagues and youngsters. Now, I was just now telling you that there has been a huge therapeutic armamentarium available with us in managing diabetes and dysglycemia. When we are talking about SGLT2s, don't think SGLT2s will solve all dysglycemia problems. No, people will continue needing other drugs. People will need insulin. People will need GLP-1 receptor agonists. It is one of those agents moderately effective hypoglycemic agent. Be very clear about it. But we are looking at that's what I'm saying, that if a person is otherwise, you see, now suppose you go SGLT2 inhibitor also, and his hemoglobin A1C is 8.5, 2 years down the line, you will still add insulin, you will still add better therapies. I mean, there is no doubt in that. My point is, at an earlier stage, even when his HbA1c is reasonably okay, and if we find out that there are certain investigative or clinical suggestions of a falling renal function, given the data that we have, DAPA-CKD, we need to incorporate it. And another, Professor Fisher, I would like you to address a very important question here that is being discussed in endocrine and cardiac circles quite a bit in the country. Now, as you said, heart failure is becoming quite common now and related to huge coronary artery disease. And most of the heart failure registries have shown 30–40% of people admitted with heart failure in the hospitals are diabetics. And overall outcomes in diabetics are not as good as in non-diabetics because they are associated more than one. You see, you cannot have a clean heart failure in a diabetic. He will have a significant atherosclerotic disease. He will have a microvascular disease. He will have an element of diabetic cardiomyopathy. He will have a myocyte dysfunction at multiple levels. The point here is that if his ejection fraction, Bobby was telling us, was 45. Did you say that?
Yes, sir.
Now imagine let's say instead of 45, it was 35. Left ventricular ejection fraction was 35. So he would qualify for a heart failure with reduced ejection fraction. So understandably, SGLT2s would have a huge role because this is one area that Professor Fisher talked about. If you look at all cardiovascular outcome trials of all the known SGLT2 inhibitors, the results have been very heterogeneous, but there has been only one homogeneity, that all cause reduction in hospitalization for heart failure. There is nothing common between Amparang and Vertis trial, but heart failure reduction. There is nothing common between Canvas and Amparang, but heart failure. So, now suppose this, I will recapitulate the question. Now, this particular patient whose diabetes is well controlled, whose hypertension is well controlled, and we do not need an additional drug for managing his diabetes, and now he has a heart failure. Now, would you give him guideline-directed medication, like, would you choose a drug like SGLT2 inhibitor or an ERNI or a sacubitril/valsartan combination?
I would suggest
Bobby and then Mahesh. Bobby, that's Dr. Fisher and then Mahesh. Yes, Professor Fisher.
All right. Well, I would suggest if somebody like that, I would be switching them. So supposing they were, well controlled on medium strength metformin and linagliptin, but has a heart failure with a reduced ejection fraction, I would be saying you want to stop the linagliptin, substitute dapagliflozin, and in that subject, your dapagliflozin is for heart failure prognosis, for renal prognosis, and to continue to manage the diabetes. Whereas linagliptin, the only thing you're doing with that is getting your HbA1c down. It doesn't give you any cardiac or renal protection. So I think we are getting much better now about thinking about switching tablets rather than just adding in. And yes, if you're diagnosing heart failure for the first time, then you want to make sure that they are on all the heart failure therapies that whatever the local guidelines say, and that would be ACEs, ARBs, mineral and aldosterone receptor antagonists, beta blockers as well. So it's a lot of medications for a heart failure patient, but it does them good. So yeah.
In the last half a decade, ERNI has emerged as a frontline management for heart failure. At what stage in this particular patient we decide that probably we need to give some additional drugs for heart failure apart from SGLT2 inhibitors?
Well, that's a good question. I think we have a cardiologist speaking next, but I work closely alongside John McMurray, who's one of the top cardiologists in the world and has been involved in lots of these trials. And certainly from a heart failure guidelines point of view, if you start, if it's an ACE and then a beta blocker and then an ARNI or switch to an ARNI or etc., it could be several months before an SGLT2 is introduced. So they're thinking either of starting all of these at the same time or actually making SGLT2s the first one, because it's one dose. The other ones are much more complicated to use. So just now there is a lot of discussion around the guidelines for heart failure about can you start them all at once? Yeah.
Dr. Fulwani, you wanted to make a comment?
Yeah, actually, I just wanted to say that I have a case. I will be discussing a case which is almost similar to what you are saying, that a patient is there.
Then let us get along with your case and then we'll discuss that thereafter.
That should be good. That should be correct.
Go ahead.
Yeah. Okay, is it okay?
Yeah, perfect.
Yeah. So this is a 68-year-old gentleman who has retired, and he is diagnosed to have heart failure with reduced ejection fraction 3 months back. He is class 3 NYHA. His LV ejection fraction is 28%, and his BMI is 29. He is hypertensive. He is diabetic, type 2 diabetic. He has dyslipidemia. He has coronary artery disease. He has past MI. He has an angioplasty done 5 years back. His blood pressure is well controlled. Heart rate is okay. He does not have clinical heart failure at risk now. His creatinine is 1.4. B1 is normal. eGFR is 65. HbA1c, as you suggest, as you we were discussing, 7.5. Electrolytes are normal. Sugar is slightly higher, and he is on carvedilol, metformin, aspirin, teneligliptin, atorvastatin, and hydrochlorothiazide. What next? So, as Dr. Bobby Matthews and you were all saying, how do we go ahead with adding the drugs for control of heart failure? This is what Professor McMurray has suggested. It may or may not be very correct, but then this is a very, very interesting thing, that we should have a rapid sequencing of drugs, right? 4 drugs in 4 weeks, and that is called as foundation 4 therapies or heart failure management. And what has been suggested is step 1 with beta blocker and SGLT2 inhibitor, right? And immediate starting beta blocker, maybe either carvedilol or bisoprolol, and SGLT2 inhibitor like dapagliflozin or maybe even empagliflozin. And in a week's time, you think about ARNI, right? Then in a week's or maybe 2 weeks time. Sorry?
This would hold true if a patient was non-diabetic also, because now SGLT2s are approved for heart failure. This would hold true for a non-diabetic also?
Yes, yes. Then in next 1 or 2 weeks, you add MRA. So this is what is what was surprising to all of us. It has been published in 21 only, March 21. And what we were following till now was beta blocker and ARNI to start with. And then in couple of weeks, we would add MRA. And then we'll add the SGLT2. But as you all were saying, and even Professor McMurray has suggested, that we should be very aggressively thinking about adding the SGLT2 inhibitors right on day 1, or as a step 1 in the management of heart failure. So what this patient who is on carvedilol, we would continue it. Metformin, obviously, we would continue it. Aspirin will continue it. Teneligliptin, I don't know how right we are in continuing or starting or even adding teneligliptin to a patient who is this kind of a prototype patient. But certainly we would add dapagliflozin over here, and then ARNI next week. What are your suggestions? Everybody's suggestions now.
And before I forget, I want to add a comment on that enagliptin, because we have had a problem with some of the gliptins with heart failure.
Okay.
And we have already known that that happened with saxagliptin, that happened with alogliptin.
Yeah.
And even though TCOS did not show any increase in heart failures, But there has been a general feeling that gliptins have something got to do with fluid retention in the body. I'm just like, linagliptin did not show that. Gliptin and allogliptin showed in the clinical trials. And tenaligliptin, we don't have a dedicated cardiovascular outcome trial. So like there is a anecdotal data which cannot be a substitute to a well-conceived randomized control trial. And that anecdotal data, I call them, they are stories concocted by people like you and me. I also created many of those stories. I would not run away from the responsibility, but that you create on the spur of the moment. But so tenaligliptin is something that I can understand the market is our patients are quite a bit cost sensitive, but someone who has had either a bypass surgery or an angioplasty cannot be casually treated, because as Dr. Fisher was very rightly saying, at the end of the day, whenever you treat diabetes, dysglycemia, only trying to improve the vascular health. At the end of the day, whatever you do, you're trying. And if vascular health is already compromised to that extent, you cannot expose him to a drug where there is a potentiality of further damage of the either endothelium or vascular system. Are you done with any other, Mahesh?
No, that's what I wanted to say. That a patient who has heart failure with reduced ejection fraction, whether it's diabetic or non-diabetic, rapid sequencing of drugs to control heart failure should be thought of. Unfortunately, it is not being practiced widely, even in the tertiary care centers by cardiologists or by everybody. We don't add SGLT2 rapidly to start with. We definitely start with beta blockers and ARNI. Then SGLT2 should be added, or maybe it can be first line as suggested by Professor Murray. Your take, Professor Fisher. What is your opinion and suggestion?
Yeah, I agree completely. I mean, I'm very much influenced by what Prof. McMurray says. I mean, the one thing about dapagliflozin is it's a single dose SGLT2s, whereas even beta blockers, you start a dose and then titrate it up. So that's why I think that you can get in SGLT2 inhibitors very early, and the other therapies, if you can get them within 4 weeks, you often then need to involve other members of the healthcare team, because a cardiologist may initiate but won't be seeing people back in the 4 weeks. So it might require somebody else, whether it's and in the European practice, we have heart failure nurse specialists who will follow up the patient and make sure that the doses of all these therapies are titrated. But yeah, I think as early as possible, if what they're calling it is rapid sequencing, then I think that's exactly the way forward, yeah. Because you get rapid benefit, yeah.
I think, as Dr. Fulwani very rightly said, if the patient is a diabetic patient and you have a suspicion or a confirmed heart failure with reduced ejection fraction, giving of SGLT2 is absolutely no problem. And that is now, what ADA 2021 also advocates. But if you look at American College of Cardiology and recommendation of 2021, and all the data is now in public domain from all the cardiovascular outcome trials from the SGLT2 inhibitors, and everything has been discussed right from 1951 till today. If a person is a non-diabetic, my question was, Fulwani, if the patient is a non-diabetic and you have a scenario like this, so obviously, even though we have a data in non-diabetics also with SGLT2 inhibitors, but today, given the amazing data from paradigm trials, a huge number of trials, and the benefits that they have shown, amazing in comparison to standard treatment comparator was enalapril, because that's what was the standard treatment for beta blockers, enalapril, and then, when out in this spironolactones and things like that. In today's guideline-directed medication, in a non-diabetic patient, do we retain this sequence of events, or we add beta blockers and ARNI in a progressively increasing dose, or SGLT2 inhibitor in a non-diabetic population?
So, as I said, what we were practicing till now also, and we still continue that we would always add ARNI first, beta blockers, then SGLT2. Unfortunately, this is true. I don't know whether we are 100% right or we are wrong, but there cannot be a head-to-head comparison between ARNI and SGLT2. Nobody can be wrong whether you start SGLT2 or you start ARNI, because both drugs have shown phenomenal benefit. Especially ARNI has shown a huge benefit in paradigm heart failure trial. That over and above enalapril, there is a huge benefit, and therefore the recommendation level is class 1B, right? And we are supposed to start that drug on day one only.
You know, again, also, Dr. Fulwani, a lot of data has come with this sacubitril/valsartan combination that it helps remodulating the heart, reducing the left ventricular hypertrophy. And so, like, if you're able to reduce some of the underlying pathophysiological mechanisms of heart failure, in the long run, it's meant to do good. I'm not aware of whether these happen. There are some smaller studies, apart from paradigm study, which have shown that. So that's what I'm saying, that probably a time is coming whenever you have a resistant heart failure, both. Yeah, Arundhati, you want to make a comment?
I want to put in a question, sir, rather than a comment. Now, we're talking about so much about heart failure and diabetes. I'm talking about the diabetes section. But I always feel that we underdiagnose heart failure in diabetics. So do you think it is about time that none of the guidelines tell us about doing an echo unless the patient is symptomatic? Even the routine ECG is like only if the patient maybe annually, nothing more than that. Do you think we should be a little more vigilant about heart failure, maybe include at least an echo in the guidelines as to how about we should go about investigating our diabetic patients?
I would say, you know,
or is there any role of any risk calculator?
I would explain on that, but, you know, I must tell you, you are absolutely right. We have become complacent, you know, whenever we have some symptoms that we attribute to cardiovascular system. We believe that a good dose of ACE inhibitor, ARB, and a good dose of statin will do the magic and everything will be taken care of. Unfortunately, I'm sure we'll ask the cardiologist, but I'm saying it from a endocrinologist point of view, who has seen all this happening for decades and decades and decades. So if I think time has come that we need to look at it from a non-coronary artery disease as well. And heart failure needs to be more frequently diagnosed. One, it is not all that uncommon. Two, that 1/4 to 40% of hospitalization for heart failure happens in diabetics, and three, the outcome is worse than in non-diabetics. So, Professor Dr. Mahesh would like to make a comment on that.
Yeah, it is, as you say, is very correct. Whatever patients who are hospitalized with heart failure, almost 40 to 50% do have diabetes, number one. Number two, overall diabetic population, almost 30-35% will have heart failure sometime in near future. Number three, the mortality of heart failure, as it is very high. If it is chronic heart failure, there is a 50% 5-year mortality. And 1-year mortality is more than 20-25%. Number four, almost only 30% of populations who are discharged from hospital are given proper therapy for heart failure. So this is irony of situation. So as you were saying, that we must be very, very rigid or very careful in doing an echocardiography or advising an echocardiography to a patient who has diabetes, and even if he's even if he's asymptomatic, because by the time we wait for symptoms to occur, we may have already missed the bus.
You know, we don't have to wait for the ejection fraction of 24 or 22. I'm so like, you know, we should pick it up at 45. And many people would think even at 50, it isn't that good. Prevent the slide at that time. It is easier.
The other thing though is to think about, number one, we'll get data by the end of the year about whether patients who've got the heart failure syndrome with a preserved ejection fraction also benefit. BNP or other natriuretic peptides can be used as a screening test, or certainly in most European practice, rather than screening it, it would be for having a high index of clinical suspicion. But a BNP is a very good marker because that is much more readily available in many systems than an echocardiogram.
Absolutely perfect. You know, now and terminal pro BNP, We used to talk about it half a decade back. Now today it is available. No, not that readily as you get a thyroid function test done, but is reasonably available if you look for it. And it is a surrogate marker of fluid retention and impending heart failure. And I must tell you, it's a far better marker in diabetics than in non-diabetics. Look back at many trials, data available already in public domain. That is a far better indicator of a fluid retaining state in a diabetic population, and then is going to be an amazingly good surrogate marker for making a diagnosis of heart failure. But it's not that widely available given the sort of population that we have. But echocardiography has become reasonably available everywhere. I'm just like that's a silver lining. I'm just like there is no smallish big stage that cardiologists or physician cardiologists, physician endocrinologists who do echos on their own. Now for the last case, Arundhati.
So in my case, I'll be presenting three cases, three slides. Just to go back from where SGLT2 inhibitor started from as an anti-hyperglycemic agent, I mean, as an oral anti-diabetic, we know that it has given us a lot of benefits in terms of cardiovascular benefit, in terms of renal benefits. But if we talk about the population wherein we do not have these problems, and that is a huge chunk of the population that we're seeing. So where should SGLT2 inhibitors come in? Those group of patients is what we'll like to discuss. So the first case is a 28-year-old who's been recently diagnosed with diabetes for the last 6 months. She's been on lifestyle, not started on any medicine. Her BMI is at 31, BP is 130/90. She also gives a history of menstrual irregularity with an ultrasound showing a PCOD pattern, irregular lifestyle, HbA1c, as you can see, 9.5, creatinine, ACR levels are good, LDL is at 165. So HbA1c of 9.5, would you be initiating only metformin? Would you be thinking of a dual therapy where you would include an SGLT2 inhibitor, given the fact that the patient is obese, has an irregular menstrual pattern and others which are basically signs of other insulin resistance? So what would you do there? A second case, he's a 44-year-old who's been a diabetic for the last 5 years. He's hypertensive. His BMI also stands at 29. His HbA1c is 8.1, creatinine is 0.8, ACR is 86. So a little bit of rise in the ACR there, but GFR more or less stable, lipids are normal. And he has a family history of an ischemic heart disease. Presently, he's on 1 gram BD of metformin and glimepiride 2 milligram. So his HbA1c levels are not controlled. He's obese. He's got a family history of ischemic heart disease. As of now, he's not symptomatic, and a slight rise in the ACR levels. Would you think of an SGLT2 inhibitor in this scenario? And the third person is a person who's been a diabetic for the last 10 years. He doesn't have any history of MI or stroke and angina and others, but his HbA1c is not controlled. It's at 8. His creatinine is slightly edging over. It's at 1.1. He has a BMI of 30 and a BP of 140/90. Presently, he's on 1500 metformin and linagliptin, apart from telmisartan and rosuvastatin. So in all these three scenarios, a newly diagnosed, a person who's been a diabetic for the last 5 years on dual therapy, sulfonylurea and metformin, and a third person who's been a diabetic for the last 10 years, creatinine at 1.1, slightly edging over, and HbA1c not controlled on linagliptin and metformin. So in all these three patients, we're looking at HbA1c lowering, we're looking at weight reduction with minimal hypoglycemia, of course. Are there any additional benefits in these cohorts of patients? Will we be offering any primary prevention benefits if we add SGLT2 inhibitors to these three groups of patients, to these three patients?
Arundhati, we'll start with the first patient. It looks more fascinating to me. The second and third are the conventional ones, a young lady. I've been seeing people for decades now, ever since I have been an endocrinologist. We have been seeing, this epidemiological transition in diabetes I have seen right in front of me. Initially getting people, type 2 diabetics who were 45 or 50, life expectancy being 55, 58. So complications, you hardly lived for a time, you will develop major complications. Now the same, I've seen in this last 3.5, 4 decades, trickling down to now, I see huge number of people with polycystic ovarian syndrome and dysglycemia. And we have published data in Journal of Reproductive Biology and Endocrinology more than a decade back, where we showed that polycystic ovarian syndrome is an insulin-resistant state, and 1/3 of general population who, young ladies like her, epidemiological study published by us, have a suggestion of a polycystic ovarian morphology in the ovaries. So my one observation on this would be one, that whenever a person has diabetes, because now diabetes is occurring in 20s, she's already a diabetic at 28, a beautiful young lady, 28, and looking at a huge life. I'm saying, like, now when a life expectancy by the time she gets old would be 75, 80, even in India also, because we have seen an increase of more than a decade and a half in the last 2-3 decades in our life expectancy. So I keep on telling people, optimize to the lowest possible HbA1c at the earliest stage, because this is a population where you would not have a major problem with hypoglycemia, with gliptins, metformin, and SGLT2s. If you give an excellent control for next 20 years, you are pushing off all the complications by another 2 decades. So never lose this opportunity. It is not that it will not do a benefit in that 68-year-old guy, but the maximum benefit you will derive now. And you can imagine now, Arundhati, that this young lady is already having an LDL of 165. It petrifies me at 28. And it must have been at 140 when she was 25. And it must have been 120 when she was 20. And I see a TGs of 600, 700 in young girls who are 18, 20. So, but the only connotation I will have in this particular patient, if she has a polycystic ovarian syndrome, she has a menstrual irregularities, and if she is looking for a marriage or is married and looking for fertility, then I would be a little bit hesitant till she completes her family, because pregnancy is a very dynamic state. You get married, you get.
So we would not advise pregnancy at this stage anyway. So would it not
This
be?
is what I'm telling you. In India, you get married. I'm saying, like, there's no planned pregnancy. You get married and it just happens. So we just need to be careful that way. But if a family is complete, lactation is complete, it's been an amazing thing to do. I would totally agree with that. Anyone wants to make a comment on that? Because I think, and now understandably, the second observation I'll make, which my cardiology friend and Professor Fisher would talk about, your last third case, that he has diabetes mellitus of 10 years duration. He, his LDL is 105. He has no history of stroke, etc., heart failure, blah, blah, blah. His BMI is 30. Blood pressure 140/90. You can take it for granted. Depending on how aggressively you look for coronary artery disease in him, you will find it. It's extremely unlikely a person who is a diabetic for 10 years, who is hypertensive, whose HbA1c today is 100, whose LDL is today 105, and whose BMI is 30, and he has waist around 98. I would put my last bet on it. Depending on what investigation you use, you will find out a significant surgery. It is only that it has not become critical, that it will become symptomatic. He has not had an MI yet. He's not yet developing an unstable angina, or we are not looking for it.
So the point that I wanted to drive home was that as endocrinologists, as physicians, not cardiologists, they will be getting the patients after everything has developed. So this 3 category of patients, in all the 3,
absolutely,
the use of SGLT2 inhibitors, we have an opportunity to not only decrease the HbA1c, which we are primarily looking at, but also probably provide the primary prevention or secondary, as you're saying, it might already well planned.
Arundhati, you're absolutely right. SGLT2s do help at every stage. There's huge data coming up in people who are 65 and above in the public domain now available. But my point is, in the first case, first lesson is for all our young colleagues is that optimize hemoglobin A1c. SGLT2 is an amazing drug with that, because we see a lot of obese youngsters now in the country. Incidentally, the data has shown, we have been a part of this global data. Indian women were at position number 19 in terms of an obese circle in 1975. And we are now at position number 3. We have the highest number of obese females after China and United States. This data is a part of a global data. We have been a part of it, published in Lancet in May 2017. So you will find a lot, and this is getting worse. 2 years back in Lancet, again, we published a paper where we showed that obesity has become tenfold more in adolescents and young adults, tenfold more. So you will see more of such people in practice. Professor Fisher, Professor Fisher, we are now almost done with the time. Can we have your last comments on?
No, we're sure. We actually in our clinic see a lot of patients like that woman now. In clinical practice in the United Kingdom, the majority of patients with type 2 diabetes are looked after by their general practitioner, the family doctor. But in Glasgow, we have said that anyone under the age of 40, we want to see in our diabetes clinic. And that was to try and pick up pancreatic diabetes, which we have a lot of, unfortunately related to alcohol abuse. And we've also picked up a lot of genetic diabetes, MODIs. But the majority of people who develop diabetes under the age of 40 are exactly like this: obese youngsters who've got standard type 2 diabetes. And yep, we would consider an SGLT2 inhibitor, we would consider a GLP-1 receptor agonist. We would ask them in detail about plans for pregnancy because, as you say, these are untrialed in pregnancy, and therefore, and the other thing we'd think about, which hasn't come up today, is bariatric surgery. We would be thinking about bariatric surgery. And then final point, I'm a very keen cyclist. We would try and get lifestyle change if possible and try and intensify. So we try and give everything to these youngsters because they've got the most to benefit because they've got the longest life ahead. I agree completely.
Bobby, a last word from you.
I think, sir, basically the first patient, the basic diet, lifestyle, weight loss, metformin, SGLT2. If that doesn't make the target HbA1c, you have to go for a GLP-1 analog. We are not discussing about GLP-1 analog, but that's a good option for the first patient. Second and third, one thing I'm saying, we know the guidelines. We don't want too much intensive glycemic control at extremities of age. Age more than 65 years, we want a more liberal control at the age of HbA1c 7.5 or even 8, because producing a hypoglycemia is much more worsening for an autonomic neuropathy than a hyperglycemia. But we have been discussing only agents which produce no hypoglycemia, that's sure. But it's not for you and me as a general crowd. General crowd, you are hearing too much intensive control at the age of 65 years, 68 years, keeping HbA1c 7, 6.5. We don't want. We are happy here because we are putting a gliptin, we are putting an SGLT2 metformin. We are not putting sulfonylurea and insulin, which produces hypoglycemia. This is the only thing I want to say.
Dr. Fulwani, you would like to make a last comment?
No, just as suggested, be very careful when a patient who is diabetic coming to you in regular evaluation. Please be careful for diagnosing them with them for heart failure or coronary artery disease, because it is extremely common. As you said, it is impossible to have diabetes of 10 years, obesity, LDL of 105, not to have a coronary artery disease. We see every day, many patients who have coronary artery disease and they are diabetics. Professor Fisher, one just personal comment, very personal. You have a beautiful tortoise sitting behind you. You are muted.
Sorry about that. It's a terrapin.
Okay,
Yes.
I have a similar.
Sorry, I didn't mean to say it's a red-eared terrapin which I've had for over 30 years. It's more
40
than 30 years. It's probably about 35 years I've had it. But I didn't mean to steal the meeting there. Sorry.
It looks good.
Dr. Mahesh, you made an important point. If you look back at data, there was a paper published way back in 1988 in Diabetology known as Paris Prospective Trial. And it looked at IGT, not even diabetes. And the conclusion was patients with IGT may or may not develop diabetes, but they have a 2 to 3-fold increase in coronary artery disease. And they published a review data on their own patients in 1992, again in Diabetology, re-emphasizing the same thing, that most of the people with IGT may not develop diabetes, but they will have an increased tendency to develop coronary artery disease. And that's why, actually, it is a lot of papers came in late 80s about the left ventricular dysfunction in people with IGT. And that's how IGT got, sort of substantiated as a new entity. And added because it would not cause renal failure, it would not cause eye disease, but it was said that it's already affecting your heart. It's anyway killing you. So it is not an abnormal phenomenon. So that needs to be kept in mind. We have only one question, and that's in the chat box before I hand over to the organizers. What is the dose of SGLT2 inhibitor in people who are newly diagnosed diabetics? newly diagnosed diabetic or old diagnosed diabetes does not determine the dose of the drug. It is the doctor and the patient's characteristics. If you dose of the empagliflozin is 10 and 25 milligrams, canagliflozin is 100 to 300 milligrams, and dapagliflozin is 10 milligrams, and some people use a relatively smallish dose. And if you are looking at glycemic control, try to give the maximum dose so that you get the minimum HbA1c. I've been an endocrinologist for 4 decades. No, in my own institutional practice as a professor of endocrinology, we would be delighted to have a hemoglobin A1c of 7.2 and 7.5 in that sulfonylurea era. But now today, regularly, we are seeing a hemoglobin A1c of 5.2, 5.8, 5.6 with these newer molecules without any problems. So this benefit needs to be extended to as many people as possible. And I think this should answer the question Dr. Sudhakar has asked us. And over to Dr. Abhijit. We are done with your time.
Thank you, sir. It was really a wonderful, discussion done by definitely under the guidance of you with Dr. Fisher and our panelists. Now I request Mr. Musarrif Pasha. He's the BU head of Metabolic Division of Alkem to give vote of thanks to everyone. Over to you, Mr. Pasha.
Thank you very much, gentlemen. We come to the end of a wonderful academic feast. And, this academic grant for this academic feast was brought to you by Dapanom, the Indian dapagliflozin brand with the originator salt. It will be only fair from my side to take this opportunity to thank Professor Mainz Fisher for his wonderful talk, and enlightening the evening with a wonderful scientific session. And I would also like to thank our moderator, Dr. Zargar, who is a wonderful friend of mine, for moderating this session in a very neutral manner and, in taking this evening in a very wonderful manner. I would also like to thank Dr. Arundhati Das. I would also like to thank Dr. Arundhati Das Gupta for her wonderful insights. And I would like to thank Dr. Mahesh Pulwani, for presenting the cardiologist perspective. Again, I'd like to take this opportunity to thank Dr. Bobby K. Matthew, one of my good friends. He's also known as the Talking Harrison. A wonderful evening, my dear friends. And, I also would like to, share with you guys, we had almost 7,500 registrations for today's program. This has been possible because of, the kind of content you people provided and the kind of information, unbiased information which you people provided. Before I end, I would like to take this opportunity to reaffirm Alkem's commitments towards academic and scientific-based medicine. With this, I would like to end my talk and thank all the participating doctors for becoming a part of this program. Thank you very much.
Enjoyed the whole evening. Thank you so much.
Thank you.
Thank you, sir. Thank you, sir.
Mahesh today.
Thank you.
God bless you.
Thank you,
Take
sir.
care.
All the best.
Thank you, sir.
Fisher, take care. Bye-bye. Wonderful time. Musharraf bhai, take care.
Thank you very much.
Thank you.
Enjoyed it.
Abhijit, good job.
Thank you,
Good
sir.
job. Bye-bye.
Thank you, sir.
Thank you, sir.
Excellent talk. I wish we could have discussed your 3 cases only throughout the webinar.
Yes.
I'm sorry, we had to truncate it. Otherwise, they were amazing. And they gave really different perspective. Bye-bye.
Bye-bye.
Thank you, sir.
I'm just sharing the podium with you. God bless you. Musharraf, thank you so much. I hope
Thank
program
you very much.
went well.
Yes, sir. Your presence made it very special, sir.
Thank you so much.